Today, the topic about which we are going to discuss is pharmacological behavior management. Now, let's see about the introduction. The performance of painless procedure for the child is one of the key factors in establishing a good rapport. In case of disruptive behavior, behavior management techniques can be used. Unfortunately, in some cases, it may not be possible either due to patient lacking cooperation or the systemic background of the patient demands the use of pharmacological means. Sedation. The use of sedative agents can be done in cases where children lacking cooperation for short duration procedures or in cases of general anesthesia where premedication is required. Now let's see about the types of sedations. There are three types of sedation, that is conscious sedation, deep sedation, general anesthesia. Conscious sedation, a medically controlled state of depressed consciousness that allows protective reflexes to be maintained, retain the patient's ability to maintain a patent airway independently, continuously, and permit appropriate response by the patient to physical stimulation or verbal command. Example, open your mouth. Now let's see about the goals of conscious sedation: to provide the most comfortable, efficient, and high quality dental services for the patient, to control inappropriate behavior that interferes with such provisions of care, to provide a positive psychological attitude towards future care. Now let's see about its indications. Patient requiring dental treatment but can't cooperate due to lack of psychological or emotional maturity, medical, physical, cognitive disability, fearful and highly anxious behavior, a patient whose gag reflexes interferes with dental care. Now let's see about the various sedation techniques. Various sedation techniques includes inhalation sedation, oral sedation, intramuscular sedation, submucous sedation, intravenous sedation, and rectal sedation. Now let's see about the inhalation sedation. This is the recommended route for conscious sedation for pediatric dentistry. This technique is more reliable in terms of onset and recovery. Efficacy is reduced when children object to nasal hood or have difficult breathing through the nose. Third point is that the use of rubber dam improves the effect of sedation and reduces atmospheric pollution. Nitric oxide sedation. This is the only inhalation agent that meets the requirement of conscious sedation. Nitrous oxide is a sweet-smelling, colorless, non-inflammable inert gas and is compressed in cylinders as a liquid that vaporizes on release. It has a rapid blood gas coefficient of 0.47 and has rapid onset and recovery time due to low solubility in blood. Should be offered to children with mild to moderate anxiety to enable them to accept dental treatment, and can be used to facilitate dental extractions in children. It is preferred to general anesthesia for anxious children undergoing elective orthodontic extractions. Nitrous oxide inhalation offsets the increase in pulse and BP that is related to increased anxiety and facilitates coping across the sequential visits. Now let's see about the adverse effects. Exposure to nitrous oxide can result in the depression of vitamin B12 activity, leading to the impaired RNA synthesis and nausea, liver toxicity, recreational abuse. Now let's see about the disadvantages. Objectionable taste, variable results, variable consistency, difficulty in reversal of unwanted effects, and slow recovery. Contraindications are tonsillitis, nasal blockage, common cold, very young children, and preoperative child. And procedures of administration: thorough inspection of equipment, placement of the mask over the nose, and bag is filled with 100% oxygen and delivered to the patient for 2 to 3 minutes, and slowly introduce nitrous oxide. Encourage the patient to breathe through the nose and explain the sensation to be felt: floating, giddy, tingling of digit. Adjust the concentration to 30% nitrous oxide and 70% oxygen. Carry out the procedure with continuous monitoring. After completion of procedure, give 100% of oxygen for 5 minutes. Now let's see about the clinical findings during maintenance period and inappropriate procedures to follow for nitrous oxide. Clinical findings: reduce activity of the eyes, either closed or comfortably fixed towards ceiling, which means good sedation, no changes needed. Increase activity of the eyes, probably needs positive verbal support, and increase oxygen nitrous oxide ratio. Fixed heart stare of the eyes, too deep, approaching excitation stage, reduces nitrous oxide oxygen ratio. Arms and leg cross, patient is not relaxed yet, needs more nitrous oxide. Patient talks too much, may need improve fit of nose piece or prevent dilution with air or increase nitrous oxide. Patient answers slowly and deliberately, good sedation. Patient does not answer, may be tired and asleep. If in doubt, arouse patient by physically proudly and check verbally. Perspiration appears on face, indicates onset of peripheral vasodilation. No carnage in ratio of gases needed. Reassure patient that this is suspected and will pass. And paresthesia, numbness or tingling of extremities, indicates early phase of stage 1 and is closely related to peripheral vasodilation. Paresthesia of lips, tongues, or oral tissue indicates more profound depth, probably achieving analgesia, and permits ingestion of local anesthetic to be given comfortably. Intramuscular sedation, anatomic consideration of the injection site and additional training of the operator is required. For most patients, the outer quadrant of gluteal region is safest, but in small children, anterior thigh is the preferred site. This technique is not at all recommended in children. And now let's see about the submucosal sedation. This involves deposition of drug beneath the mucosa. Best method is intranasal. The oral site usually chosen is the buccal vestibule. IV sedation, this is the easiest, more efficient and safest method of parenteral sedation next to inhalation sedation. The onset of action is 30 seconds. IV sedation should be carried out in a hospital facility for children below 14 years of age. For adolescent, IV Midazolam can be administered. Disadvantages are frequent monitoring, phlebitis, hematoma at the site. Rectal sedation, shortest duration of onset, requires a low dose. It is currently not recommended without a hospital facility and requires the assistance of qualified anesthetic. Deep sedation. Midazolam sedation. It is generally reserved for anxious adolescents or adult patients. It has a more rapid onset and recovery, produces a greater degree of amnesia than diazepam in dental patients. Pharmacological agents such as erythromycin, calcium channel blockers, and antifungal can inhibit in midazolam metabolism, resulting in a lengthier sedative effect. Oral administration, tablet form or syrup form. Peak plasma concentration is reached within 20 minutes. After 45 minutes, the sedation effect waves off. Elimination, half time is 2 hours, which facilitates a faster recovery. Tablets are given 60 minutes before dental treatment, and syrup form given 20 to 30 minutes before. Dosage in children less than 25 kg, 0.3 to 0.5 mg per kilogram. Maximum dose is 12 mg, greater than 25 kg, 12 mg of midazolam should be given. And IV Midazolam used widely in adults, and intranasal Midazolam produces sedation in 5 minutes. Nasal spray. Disadvantages are reports of occasional respiratory depression, transient burning, discomfort affecting nasal mucosa, not recommended in children with copious nasal secretion or who suffers from upper respiratory tract infections. Rectal Midazolam, short duration of onset, requires a low dosage, easily administered, and the dose is child less than 25 kg of weight, 0.3 to 0.4 mg per kilogram. Maximum dosage is 10 mg per for midazolam, and child greater than 25 kg of weight shall have 10 weight. Chlorohydrate sedation. It's a weak analgesia and psychosedative with an elimination half-life of approximately 8 hours. In small dose, mild sedation occurs, and intermediate doses natural sleep is produced. Contraindication, children with heart disease and renal or hepatic impairment. Now let's see about the general anesthesia. Drugs which produces reversible sedation of sensation of all sensation and consciousness. Objective: provides safe, efficient, and effective dental care, eliminates anxiety, produces untoward movement and reaction to dental treatment, aid in treatment of medically, mentally, or physically challenged patients, eliminates the patient's pain response. Let's see about the indications. Patient for whom local anesthesia is ineffective because of acute infection, anatomic variation, or allergy, extremely uncooperative, fearful, anxious, or uncommunicative child or adolescent, patient requiring significant surgical procedure, patient requiring immediate comprehensive oral care. Contraindications are predisposing medical conditions which would make general anesthesia inadvisable, a healthy cooperative patients with minimal dental needs. Now let's see about the drugs used for pre-anesthetic medication. Opioids, morphine 10 mg to pethidine 50 to 100 mg intramuscularly. The allay, anxiety, and apprehension of the operation produces pre- and post-operative analgesia, smooth induction, reduces the dose of anesthetic required, and supplement poor analgesic, and to reduce post-operative restlessness. Its disadvantages are depressed respiration, falling blood pressure during anesthesia, lack of amnesia, flushing, delayed gastric emptying, and biliary spasm. Sedative and anti-anxiety drugs, diazepam 5 to 10 mg, lorazepam 2 mg, orally or intramuscularly produces tranquility and smooth induction, loss of recall of post-operative pre-operative events, accentuation of post-operative vomiting. Anticholinergics, atropine 0.6 mg intramuscularly intravenous to use is to reduce salivary and bronchial secretion. Disadvantage: dryness of mouth in the pre and post-operative period may be distressing disadvantages. Neuroleptics chloropromazine 25 milligram, haloperidol 2 to 4 milligram, given intramuscularly. This allay anxiety, smoothen induction, and have anti-emetic action. Disadvantages is that potentiate respiratory depression and hypertension. H2 blockers ranitidine 150 milligram orally in patients undergoing prolonged operations, cesarean section, and obese patients at increased risk of gastric regurgitation. It reduces the pH of gastric juice and may also reduce its volume. Antiemetics, metoclopramide 10 to 20 milligram intramuscularly, effective in reducing postoperative vomiting, extrapyramidal. Disadvantages is extrapyramidal side effects and motor restlessness. Now let's see about the drugs used for general anesthesia. Inhalation, nitrous oxide, intravenous, induction agents, thiopentine, sodium hexitone, sodium propofol, etomidate, and volatile liquids, ether, halothane, isoflurane, disflurane, sevoflurane. And slower acting drugs are diazepam, lorazepam, midazolam. Dissociative anesthesia is ketamine. Opioid analgesia, fentanyl. Now let's see about the various stages of anesthesia. General anesthesia causes an irregularly descending depression of central nervous system. That is, the higher functions are lost first, and progressively lower areas of the brains are involved. There are 4 stages. That is stage of analgesia, stage of delirium, stage of anesthesia, medullary paralysis. Now let's see about the stage of analgesia. Starts from beginning of anesthesia, inhalation, and lasts up to the loss of consciousness. Patient remains conscious and can hear and see. Reflexes and respiration remains normal. Minor surgical procedures can be carried out in this stage. Stage of delirium. From loss of consciousness to beginning of regular respiration, apparent excitement is seen in many patients, like shouting, struggle, jaws are tightly closed, muscle tone increased, jerky breathing. No stimulus should be applied or operative procedures during this stage. This stage can be cut short by rapid induction and appropriate premedication. Surgical anesthesia extends from the onset of regular respiration to cessation of spontaneous breathing. Plane 1, rolling eyeballs. This plane ends when eyes become fixed. Plane 2, loss of corneal and laryngeal reflexes. Plane 3, pupil starts dilating and right light reflex is lost. And plane 4, that is intercostal paralysis, shallow abdominal respiration, dilated pupils. And medullary paralysis includes the stage from cessation of breathing to failure of circulation and death. Pupil is widely dilated, muscles are totally flabby, pulse is imperceptible, and blood pressure is very low. Now let's see about the conclusion. Use of pharmacological method of managing uncooperative children should be used only after all the behavior management modalities have proved to be unsuccessful. Thank you.